Good afternoon, everyone, and welcome to the Arizona Center for Rural Health State Office of Rural Health webinar series. Happy Telehealth Week. Some notes for the webinar as people are joining. The audience will be muted for the presentation, but we encourage you to enter questions into the Q&A or chat box function, and we'll be monitoring that as we go. All questions will be answered at the end of the webinar. Lastly, after you leave the webinar, you'll receive an email with a survey as well as the link to the recording. So if you feel like someone else may benefit from this webinar, you can go ahead and share it with them. We'd like to take a moment to say the land acknowledgement for the University of Arizona. We respectfully acknowledge that the University of Arizona is on, uh, is on land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. And with that, I will hand it over to our presenter for the day.
Thank you, Mariah. I appreciate it. And welcome to Connecting Communities, Telehealth as a Tool for Equity. And as Mariah said, happy Telehealth Awareness Week. Telehealth is expanding and breaking down disparities, but also creating some new challenges with disparities. And we really need to make sure that telehealth is available to everyone. So some having access to it and others not having access to it widens disparities, which is not what we want to hear. We do hear that there are populations do not have access due to broadband, but is that the only reason for not utilizing telehealth? So today we will explore breaking down some of those barriers and what additional research is needed to really understand the barriers to telehealth utilization. And I just want to mention that I don't have any conflicts of interest on that. So here is our agenda. As I've mentioned, telehealth is a critical component of modern healthcare, but it is creating some potentially new barriers. So we really want everyone to benefit from technology-enabled care. Next slide, please. So I just want to, when people think of telehealth, they think of the video and those visits, like we're doing the Zoom visits or another methodology. But really what I'm talking about in this presentation today is technology-enabled care. I'm talking about telehealth in the broad sense. It's just continually repeating technology-enabled care is tongue twisting, and so I'd rather not do it. So I'm going to call it telehealth, but I just want to, so I'm going to call it telehealth, but I just want you to realize that I'm talking about store and forward, remote patient monitoring, wearables, all those kinds of things. Next slide, please. So I'm going to start by talking a little bit about the impacts of disparities. And the door to healthcare access and quality is shut for many rural residents. And telehealth has opened that door for many, but not all. As you know, 1 in 5 Americans live in rural areas. Rural residents are known to have more difficulty accessing healthcare. And this is for a variety of reasons: workforce shortages, lack of an accommodating infrastructure, geographic proximity, getting time off from work, the travel costs, all those kinds of things. So telehealth, next slide, please. Thank you. Telehealth can really, I won't read all these to you, I promise. Telehealth can really improve access, and hence it can improve quality of care. And so if someone needs an assessment for dementia, for example, and there's no one in that community that does that, then they can get hooked up to the right type of specialist. Or if someone has a rare medical condition, also mental health providers. I have some couple of friends of mine who are going through some marital challenges, and he did not want to use someone. I live in a rural area. He did not want to use someone in the community for fear that it would get out. So they're using telehealth to do their marriage counseling, and it's saving their marriage, and he wouldn't have gone if he had to go local, but he's very open to doing it to someone outside or meeting with someone outside the community. And then we have people with disabilities, people who are homebound, and it also creates independence for them. People who have disabilities or are homebound that need to get caregivers or need to ask people for rides or for money for the bus or whatever, they often feel like a burden, so to speak. And so this gives them a lot of that independence, which is really important. And we know that it's important at all ages, but it's really important for older adults because they feel that some of that is slipping away. It also can bring about timely care. So if someone needs to, arrange time off from work, and so they can't get to see a provider for 6 weeks because of other responsibilities, they can do a telehealth appointment usually sooner because the other barriers are broken down. There's also people who don't have time off from work or get paid by the hour. And so like farm workers oftentimes get paid by how much they pick, for example. So if they take off from work, it's very costly for them. It also, children have less time away from school. The outcomes are really incredible there. Low income populations don't have all the expenses like the lost wages that I've mentioned. And for medical conditions that are stigmatized, such as mental health, tuberculosis, things like that, it relieves that embarrassment. And racial concordant care. People can find a provider that they align with and feel more comfortable with, which we found that increases trust. And when we increase trust, we increase the quality. So next slide, please. So this improves rural health quality of care. Like I said, I'm not going to read this to you, but these are just a few examples of how it can improve quality. It's, telehealth is often compared to in-person care. Some say that's not appropriate. It should really be compared to no care or slow care. But anyway, so you'll see that, this really helps that people are having they're completing their visits and they're getting the care that they need. Next slide, please. And it's cost effective. It's cost effective for both patients and providers and for the healthcare system as a whole. And we're seeing a lot of rural health clinics close or closing certain departments. I'm very concerned about the maternal health in rural areas with all of the closures of delivery centers there and labor and delivery centers. So if people in these rural facilities use telehealth, then they can have the lab work done. They can have, all of that done in-house. So it also helps them with being sustainable, which is really important because telehealth is not for everything. It's for a lot of things, but it's not for everything. So although I've seen babies be born using telehealth because they could not get to a tertiary care facility for complicated babies, complicated births because of weather. For example, they couldn't even get there in a medicopter. So they used a tele-ICU equipment to deliver that baby. Okay, next slide. Patients and providers, they're very satisfied with telehealth. They really want to continue with telehealth. I mean, I just look at the picture of the woman in the top right-hand corner. She probably does not want to be sitting in a clinic or in an ER. She looks a little more comfortable on her couch with her blanket, right? So a lot of providers have mentioned that improves quality of care. They've said that it reduces burnout. It helps them with seeing more patients. And so that's really important because as we know, there's workforce shortages everywhere, but particularly in rural regions for healthcare providers. Next slide, please. And telehealth can assist with continuity of care. As you can see on this data, no-show rates for medically complex patients were lower when they use telehealth. And so that continuity of care is really important. Because we don't want the no-show rate affects, especially for when they're not reimbursed for no-shows. Providers are not reimbursed for no-shows. So it helps with sustainability of facilities as well. And, having these facilities stay open contributes to improving disparities and reducing disparities. So it really helps with that. Next slide, please. And as I mentioned, it's convenient. Someone can be anywhere they want. The other issue is that we have people who travel. They travel for work. They maybe leave Colorado and go to Arizona for the winter, and they leave Arizona and go somewhere else for the summer, right? So we have people who have that. So if they can use telehealth with the primary doctor, then they have that continuity of care and they can continue. They don't have to start a treatment. And this is particularly important for people who have had long-term relationships with their providers or for mental health or complicated cases. And again, for trust and comfort and all those things. So it's convenient in terms of that for people's arrangements. When I was working on a video-based directly observed therapy project, and the people in the border areas, they would go to Mexico for a while. And so we lost them. We lost them to treatment. Well, with video-based directly observed therapy, we don't. And we know and can continue their treatment for that. So that's really important. If you know anything about tuberculosis, if they stop their medication and start again, then it becomes drug resistant and harder to treat. So it's another reason as well. Okay, next slide, please. All right, telehealth, it's a social determinant of health now. And it's becoming more and more integrated into our healthcare system, and it's going to continue on that path. And there's lots of reasons for that. It improves patient engagement. Patients have access to they have patient portals. They have more engagement, and it helps give them support outside of the clinic, right? You're in the clinic, you see your doctor for 15 minutes and you're gone. And all of the rest of the time, you're on your own to some degree to manage your health, right? And you're making those decisions. So those apps and those remote patient monitoring devices can be very helpful for patients taking control of their health and being engaged in that. So it's really become like I said, a social determinant of health. So, and thank you. You got these slides down, Mariah. You got the timing down. Great. Thank you. So is internet use what inhibits telehealth adoption? So if we look at the next slide, you can see that this is internet use by race and ethnicity, and the gap is closing. Okay. And on the next slide, you'll see that by income, the gap is closing. And the next slide, by community type, you'll see by rural versus urban versus suburban, internet use is also closing. But on the next slide, you'll see by age and education, there's still kind of a gap in there. But again, it's becoming smaller. Now, I am not saying broadband is not an issue by any sense of the imagination. But what I'm saying is that it is becoming less of a barrier. barrier. And some communities are setting up places where people can use telehealth in the library. They have a place in a fire department, a fire station, where they can use telehealth. So sometimes we have these community issues, community sites, kind of the old, I'm aging myself, telephone booths when you used to put the coins in. But people can go in and use these different community centers to do telehealth. And that's also if people have internet access, but they have 8 people in the house and they don't have a quiet place for this visit, right? And a personal space. So it can also help with those as well. Okay, so the next slide, you'll see these are just some articles that came out 22, 23, and 24 about the disparities in utilization and how there are certain groups that utilize telehealth less than others, and that there's some that use telephone only, the audio only methodology more than others as well. So if those gaps in internet use are narrowing, why are we still seeing these disparities? Next slide, please. Well, there are other factors to consider. Policies, education, structural racism. And when I say that, it can also be unintentional. Okay, I'm not saying that anyone is out intentionally to cause structural racism. Trust, literacy, and I'm also going to talk about research gaps. Next slide, please. So this has a lot on it, but if you look at policies, there was a lot of policies that were expanded the use of telehealth in Medicaid, and changes in reimbursement, changes in who could be an originating site, changes in where the patient and provider had to be physically. All of those things changed during our public health emergency. And you'll see on the next slide, these are some other policies. Like I mentioned, waiving geographic and originating site restrictions, maintaining coverage for audio only. I just want to mention this one. The data on this shows that there are people who are older adults, minorities, rural people who use audio only from those underserved regions and populations that use audio only services more. This is set to expire at the end of this year. Okay, all of these on this slide are set to expire at the end of this year. And this is a big issue. And some of these are related to, allowing rural health clinics and FQHCs to be reimbursed for providing telehealth, for them to be originating sites, in-person appointment requirements, and also who gets reimbursed for telehealth. Right now we're seeing social workers doing quite a bit of telehealth, physical therapy, physical therapists, occupational therapists, and speech therapists, and we want to continue that. And research shows that, children in particular are very comfortable using telehealth. They're used to screens. They're in some cases, they're more comfortable because you don't have the big scary adult in front of you. So, if you have a child who has a speech impediment and they may not be able to get over to the appointment, or the child may be uncomfortable, doing it via telehealth is incredibly effective. And so if these expire, we're going to have a lot of problems in terms of access issues, and we're going to leave a lot of people out there without access to care. And so, December 31st is coming very soon. And this is no way to run a healthcare system. Places can't strategically plan for whether they should build up their telehealth system or not, whether it's going to be there or not, whether to do training in it or not. Communities don't know how to address this. Do they want a place in the libraries that people can do telehealth? But if these policies do expire, those are all null issues. So right now, the discussion is that they're going to do a 2-year extension. Well, 2 years is great, but we need permanence. Why kick the can down the road? And again, with planning, right? Let's just, there's enough research out there that shows telehealth is helping underserved communities, period. The DEA, that last bullet on there, in-person requirement for prescribing Schedule II drugs was waived. Those are drugs for substance abuse treatment, ADHD, and the DEA is, from the flies on the wall that we have that we're hearing from, is right now going to not extend that, and is going to have an in-person requirement for the most part. And that's going to be a big issue. The Department of Health and Human Services is kicking back on that. So there's some interagency disagreement on that topic. But that will, again, impact access. So, education. And if you can hear my frustration with Congress, I'm sorry. we need some decisions. We need public education. People, they need to know how to access telehealth. They need information. There was a study that came out, 23% of Medicare patients did not know that telehealth was covered or not, right? So we need that. We need education about what telehealth is, that it's reimbursed, and again, how to access it. Maybe, again, people need to understand that it is available and it is covered by law. Locate providers. And providers also need to inform patients if they offer telehealth, and patients need to know to ask. And I want to touch upon this a minute because I mentioned structural racism. And like I said, it could be very non-intentional, but they may be, a provider or it may be because of resources, right? Oh, we're not going to offer telehealth because we don't have the time to, older adults don't know how to use the technology. And so we're not going to offer it to them, or we're just not going to offer it because of the expense of getting people online and things like that. So there can be some assumptions. Oh, someone is unhoused, they must not be able to use telehealth, or it's going to be a lot of resources to get them online. So that's why I say it can be certainly unintentional, or it can be based in resources, right? Resource related issues. So the next slide is about literacy and digital literacy and health literacy. Digital literacy is the ability to use technology to find, evaluate, organize, create, and communicate information safely and responsibly. Health literacy is the ability to find, understand, and use health information and services for oneself and others. So we need both, okay? And we don't have a good standard assessment tool out there to measure this on a population level. I have up here the HEALS literacy scale, which is it's very well written. It's been it is evidence-based and all that. And that is for more health, that is more for accessing health information, but not about telehealth. And so we really need one specifically for that. Yet there's no standardized one to assess that. So anyone wants to create one with me, let me know, because it's really needed. I want to talk community health improvement plans. nonprofit hospitals are required to do them every 3 years. And so we need to include telehealth questions into these community health needs assessments, and hence the community health improvement plans. Because if it's ignored and now it's a social determinant of health, we're going to be missing a lot of key issues related to health improvement. Okay. So let's talk about trust. You can see here from, I think it's the second recommendation, that they trust providers who use virtual care. It's the last one. But also trust is, we don't know, we have no data on trust in telehealth at a population level. And we're seeing trust decline overall in public health, in the CDC, among providers, nurses, although nurses are always still rated top in terms of trust. So what is it? And rural tends to have lower levels of trust than urban in general, of government agencies, for example. So we need to really dive into the trust levels in telehealth and how that trust in telehealth compares to trust to in-person care, so that we can build that trust. What is it? They just don't understand it? If they heard someone had a bad experience with it, and so that got around the community. So we really need to assess that as well. So now I'm going to chat a little bit about what else we need to move forward. And I've talked a little bit about this. And on the next slide, you'll see what we need to do and learn. Community planning to include telehealth. Like I mentioned, these community health improvement plans, critical access hospitals are required to do them. Public health departments, if they're accredited, they need to do them every 5 years. And some of them voluntarily do it. And that's accreditation by PHAB, the Public Health Accreditation Board. It is. But not all public health departments are accredited. But some of them do the needs assessments anyway, voluntarily. So we really need to include that into, so that we can build a station in the firehouse, so that we can do a social media plan, so that we can have more education in the community. Maybe we need to do some social marketing on telehealth. Maybe we need education for providers. They don't know everything, and they're so busy keeping up with all of the other stuff and the patient loads and all that stuff. So maybe we need some education for them as well. We need research factors on issues such as trust, such as structural racism. We don't have any of that information, like I mentioned. We need data on how to streamline its use by providers. And I was reading the other day a research study that said 79% of consumers want something that's easy to use. They don't want to download things. They don't want passwords. They don't want, all that kinds of stuff. They want something that's really easy. They also wanted some stuff. They wanted their telehealth to be 49% want their telehealth to be with a provider that they know. So if the providers in rural areas are not offering telehealth, then they would need to, because even in rural areas, it's still hard to get to your provider across town, right? They would go to an in-person, and they wouldn't use telehealth. So providers in rural areas need to offer these telehealth modalities as well to their rural patients, so that they can have access to their medical records, so that they have a relationship already built, which is really important. We need a valid tool to assess digital health literacy at a community level. We need to create tools that can be built into the community health needs assessment with different domains. Those domains may be trust, it may be the technological aspect, it may be experience, it may be knowledge of who to call, right? How do you get hooked up with a telehealth person? During COVID, I spent a lot of time out on Navajo Nation doing a lot of education out there as a volunteer, as well as bringing water and all those things. But people didn't understand how to navigate the system. Um, so anyway, so that's why we need those community sites, which is the next one. We need policy changes and we need permanency. Previous slide, please. Thank you. This, going at 2-year blips isn't going to help, right? People don't want to invest in these big campaigns or education efforts or technology setups if they don't know if in 2 years it's going to all go away again. At this point, we don't even know what's going to happen at the end of the year. So it's not a way to run a health system. We really need permanency on these issues. So in summary, telehealth can improve equity, but we are not reaching its full capacity. And data needs to be incorporated and drive policies, community planning, and research. The next slide is a resource for a digital health literacy curriculum in case someone wants to do some education in their area. It's by NIH, and so I thought it might be a good resource for people. And references and questions. Oh, I went through that quick.
Thank you so much. I'm going to turn it over to Jen since she's been monitoring the chat to relay any questions to you.
Thank you.
Yes, thank you, Lois. That was very interesting and very wide-reaching presentation with a lot of food for thought. Cross-cuts almost all areas, I think, of health and prevention and community resilience and preparedness, and just a lot of aspects, as well as getting into some of the real issues around delivering clinical care through telemedicine. Um, Currently, I'm not seeing any questions in the chat, but I really encourage our audience, if you do have questions, to enter them. We did have one question about whether this presentation would be available after the fact, and it will. We will provide the recording and slides. And also, Lois, there's a request for your email and contact information in the question and answer box right now. And so that will, I'm sure, be included when we post the recording and the slides. Although we'll provide it now. Thank you, Lois.
I can do it now.
Perfect. Any other questions?
I just want to touch upon something you said, Jen, which is really important, and that is emergency preparedness. And telehealth, we've seen during disasters, is incredibly valuable for people. And I'm speaking mostly of natural disasters, but our fires are increasing, our floods are increasing, our tornadoes are increasing. And so people knowing like how to reach out and get their medication during those emergencies or things like that. And also people who are on life support devices, such as oxygen, what happens when their power goes out, So those types of technologies and those connections are super important as well.
That's an excellent point. And it actually sparks a question that I have with regard to the sort of the endpoint from the user perspective of telehealth, from the consumer perspective. Many people may envision it as connection that where the consumer is in their home. But there are other scenarios where the user, the consumer might be in kind of a communal setting, say a library, um, a, group home, um, a gathering point, a respite area. And can you speak a little bit to, some of the policy considerations or maybe, how communities can plan to have those sorts of areas available for folks who may not have the setup in their home, but they can still benefit from distance health.
Yeah, thank you. That's a great point. People have done telehealth from parks, from various places. You know, we have multi-generational households, or someone is in a household with 8, 10 people, and they really don't want to talk to their mental health provider or talk to their primary provider about an itch they have, you know. Um, and so they look for these spots, right? And that is why that community, that integration into the community health needs assessment is so important, so that people can find that quiet place to go to, where no one, you know, I saw someone the other day was telling me she did a telehealth appointment in a park and was in a rural region and ran into her friend, right? And her neighbor was there. And so they came over and started talking to her. And so, you know, it was just like, well, what do you do now, right? So having that place, some of the libraries have them. And during COVID, for example, New Jersey created a whole library system of having tablets that people could check out the tablet. And they also had a private room where people could do the telehealth encounters. So on the tablets, they had all of the common platforms that people use for their telehealth visits so that it was much easier. And people use their phones and things like that as well. A friend of mine's setting one up in a fire station right now. Okay, schools are other good
Mhm.
sites. But I will say that when I'm speaking with some students at schools, they said that if they want to use the telehealth in school, that they have to go and sign up. And
Mhm.
it's for mental health only. So when they go and sign up, that's a stigma right there. Okay,
Mhm.
so I get why they need to sign up, but maybe they could do it in some other way so that when someone goes to sign, like names are there, people know that they're going in to sign up for a mental health appointment, and that kind of takes the whole point of it away,
Mhm.
you know.
Mhm.
So this incorporation into community planning is so critical. And we really need to, and I'm not seeing it. I mean, I do a ton of critical health needs assessments and they don't ask these questions other than, do you have a laptop? Can you get on the internet? Blah, 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 right? Which are important, but there's so much more to unpack there, right? Like, do you have a private place there? You know, all those kinds of things need to be in there for community planning as well. So, so you asked about policy. Now, from the policy perspective, people can access it from any place at this point in time. But what it is that providers need to be in certain areas to be able to offer telehealth. And so if they're, this was eliminated during the public health emergency, right?
Mhm.
But if we go back, then it's going to be, if you're not in a place that is a designated rural area, then you can't do
Mhm.
telehealth, right? Um, and that's the originating site kind of piece. And, you know, that's a shame for a lot of different reasons. One is, I don't know, I know we're talking rural here, but I don't know the last time someone tried to get across Los Angeles. But also in rural areas, someone may have to take 3 buses, right? Still. And the definition of rural is sometimes places are rural to me, but they don't fit the definition.
Mhm.
And so that's an issue too. So from a policy perspective, we really need these originating sites and these that policy to be open so that people can, regardless of where they are, right, to be able to access telehealth.
Yes.
And you know, the other thing is someone maybe in, when I was doing a study up in Minnesota on telehealth, you know, there were sometimes the weather was so bad they couldn't even medicopter patients, you know,
Mhm.
because of the snow. Or you have someone who has a bad back, or they're homebound, and all those other things we talked about. So it would be a shame if we reverted back to that.
Absolutely. So many good points you made in that response. And yes, I can add my name to someone who does not live in a rural area, but I've definitely appreciated many of the
Yeah.
conveniences and just ease of telehealth. So yeah, it's not being in a in a what would considered a rural area is not always the only reason why someone would seek telehealth as a modality. So we do have a couple more questions, Lois. If
Yeah.
sure if you can see them as well, but the first one is considering the numerous factors that can influence telehealth. How can different stakeholders collaborate to expand its reach to more individuals?
Great
Yeah, it's
question.
a really good question.
Um, and so the collaboration is collaborating on the topics such as educating the community members. And that needs to happen from different community-based organizations, right? So if you take someone who is unhoused, they or is a victim of human trafficking, they need a wide variety of services. They need legal services. They need oftentimes substance misuse services. They need general, you know, physical services from a primary care. So having these CBOs all at the table to understand and be able to educate and share their experiences. Hey, you know, I just tried this new methodology. It was really easy to connect. Patients are loving it. And to also share their data. You know, we're seeing an uptick in people taking or using telehealth to access dementia care, for example. And then you can see whatever education efforts that somebody else made, maybe the public health department made, how they're working. So it's really has to be community based. It has to come from, and so again, going back to community health needs assessments, which should be a bunch of stakeholders, right? You should be getting data from Planned Parenthood. You should be getting data from mental health clinics. You should be getting data from, you know, people in osteopathic care and gerontology and things like that. And as well, you know, from those providers. And like I said, social workers are they're the top users of telehealth right now in terms of professions from on a commercial insurance side. And they know a lot, they see a lot, they're out there in the field. So we really need a diverse people at the table, and a coalition is, you know, and I know everybody's like another meeting, another coalition, but a very well organized coalition that's focused on sharing best practices and sharing data and working toward a community health needs assessment that is comprehensive. So hopefully I answered that. Let me take another look at it. Yeah. Did I answer that?
Yeah, that's a lot of good things to consider there and to think about sort of
Yeah.
who or what types of organizations might be natural conveners of those types of
Mm,
coalitions and plannings. And
yeah.
in the public health world, you know, the local health departments come to mind, but also other types of networks. And as you mentioned, community hospitals and clinics are required to do these types of assessments too. So,
And
um,
let's not forget law enforcement. And
oh yeah,
let's not forget, corrections and probation and that whole community as well. Um, because, for example, I worked on a telehealth project where instead of people going to jail, we were getting them substance abuse care. And law enforcement was very instrumental in that process. So it was having them there at the table was really, really important as well. So I don't want to forget them.
mhm, mhm,
So it really needs to be everyone. The schools, for example,
mhm.
they're really important, as well as, parents and foster kids, and everybody needs to be involved in that process. So I think the key issue is bringing them all to the table. Um, and seeing, creating a plan together on how you can do that, and how you can, when people need multiple types of care, how you can make that happen seamlessly, which is really important.
Excellent, excellent. We have one further question in the Q&A right now, which is hopefully not opening up a whole debate. um, but the question is about a preferred definition of rural or rurality. And as the Arizona Center for Rural Health is our federally and state designated state office of rural health. And so um, you know, we are aware of the way that definitions of rurality at the federal and state level impact resource distribution. Um, there are also, you've mentioned how that can impact policy development and implementation. Um, so I'm going to go out on a limb and extend an opinion that it depends. But I'm curious as to whether you found any particular definitions, Lois, more friendly than others to some of the things you've been talking about, or where you would point people to learn more about the various definitions of rural and rurality.
Yeah, that's a tough one. Thank you for that gentle introduction to the question, Jen. Um, because it's hard. I mean, I said I live in rural. It's actually a town of 47,000 people. It is not considered rural, but yet I consider it rural, right? I grew up 45 minutes outside of New York City, so to me it's rural. Um, so it's, and I've been through towns of two with two people in them, um, and so I don't have a favorite definition. I think, there's these cutoffs for rural. If you're this and you're this and you're this, I see rural on a continuum, right? And that there's just not one particular cutoff point. You can have an area like where that the town I'm in, which is a large geographic region, and there are people who are way out there, to get groceries and to get access to care, and due to weather things and stuff too, it's troublesome. So what is it? The Rupri? And I always call it just RUPRI, rural. Does anyone remember what RUPRI stands for? Let me pull it up. But they tend to have some good definitions, and Mariah may have some thoughts on this as well. But it's a
No,
good question.
I think you guys summed it up really well, that it generally depends on what we're looking at, and who's defining it. So it's hard to have an exact definition or a favorite definition when you're looking at different problems.
That is why I think we should just get rid of it. And like I was saying, in these policies, to not have it be an originating site, and are they in a rural region and are they not? Oh, thank you for posting that on RUPRI. Thanks, Jen. I forget what RUPRI means. I just always call them. They have great newsletters, by the way. And because if we get rid of that originating site and we get rid of all that stuff, and everyone has access like we should, regardless of where they live, then we don't need a definition for rural. Because like I said, it's so subjective anyway. You know, it really is. So
That was beautifully put, and that looks like the last question. So I just want to take a moment to thank you sincerely for spending your time putting this presentation together and being with us today. It was very informative, and I think primed a lot of the conversations that we'll be having at our February policy forum, as well as the Rural Health Conference next year. So we loved having you this year and hope to have you there again next
I
year.
hope I get reinvited. It was really fun. It was a wonderful conference. It was nice. I had a really nice time there. I met a lot of good people, and you know, people have questions or anything like that, please let me know. Please reach out. And of course, Mariah and Jen, that extends to you as well. I'm always happy to, you know, we do have on our website, because you mentioned policy, on the American Telemedicine, sorry, someone introduced it as telehealth today. The American Telemedicine website, we have a section there for policy, and in there it has federal and state policies and all our advocacy letters. So if you're interested in seeing, you know, what's going on and what we've posted and things like that, that's a really good place for policy stuff. And we're hoping for permanency. So if anyone can advocate to that, you work through an advocacy agency, because this 2-year kicking down the road is not working. But that's my soapbox, and I do get a little passionate about it a little bit, because, you know, like Jen said, you know, or the question about the definition of rural, it shouldn't matter. You should be able to live in a town of 2 or a town of 2 million and be able to get access to the care when you need it and the type of care that you want to have. So I see no value in it, because all it does is muck things up, and there's no good definition for it. And from a telehealth perspective, anyone should have access, regardless of whether they're in the middle of Detroit or whether they're in, you know, Navajo Nation. So
That is beautifully put and such a good way to end the webinar. I don't think I could have said it any better myself. So thank you everyone for taking the time to be here today. And again, you'll get an email with the recording as well as the survey. Please take a few minutes to fill out that survey. It really helps us direct content to what you're looking for. Have a great day, everyone.
Thanks for attending. Have a great week. Bye.